about the infantile hypertrophic pyloric stenosis. This disease is the most common cause of gastric outlet obstruction in infants. There is a muscle hypertrophy and hyperplasia involving the circular layer and hypertrophy of the underlying mucosa. So the circular layer and the underlying mucosa is hypertrophied. When we check the etiology, we say that boys are like 2 to 5 times more impacted, more affected by this disease. And this disease generally affects the firstborn infants. And the peak occurrence is between 3 to 5 weeks or 2 to 8 weeks. So if a newborn is like 2 days old and he's vomiting, we do not suspect from pyloric stenosis because this presentation of this disease takes like 3 to 5 weeks. It is a progressive disease in muscle. When we check the anatomical view, we see a pathologic view. There is a hypertrophy of the pyloric muscle, and when we look at the pyloric canal, it is elongated. During radiography, we see it elongated and thinner because of hypertrophic muscle. There are some very typical clinical features. Infant is vomiting, and it's a non-bilous vomiting, and infant is vomiting projectile. And because the infant vomits, we see gastritis and esophagitis, and this brings brownish discoloration or coffee ground appearance to the vomit. Infant is always hungry, has diarrhea because of starvation stools. There's dehydration, this makes the infant very lethargic. And jaundice, because indirect hyperbilirubinemia, secondary to glucuronidase deficiency. Differential diagnosis: pylorospasm, gastroesophageal reflux disease, gastroenteritis, food allergy, increase in intracranial pressure, vomits, metabolic disorders, adrenogenital syndrome, antral webs, pyloric atresia, duplication cyst of the intrapyloric region, ectopic pancreatic tissue within the pyloric muscle. Diagnosis: there's numbellus with projectile vomiting, visible peristaltic waves in the left upper part of the abdomen because of the gastric outlet obstruction, and there's a very specific, very typical metabolic disarrangement due to vomiting. We see hypochloremic, hypokalemic, metabolic alkalosis. Diagnosis can be done by careful physical examination, palpating an enlarged pylorus, and it's called olive sign. Infant must be calm, warm, and cooperative. Use a pacifier or a small feeding, like 5% dextrose. If the stomach is distended, aspiration with a nasogastric tube. In USAGA, if like we couldn't palpate it, we couldn't decide, we do radiologic examination. Pyloric muscle thickness is more than 4 mm. And if it's a premature infant, we get the cutoff as 3.5 millimeters. And pyloric canal length is more than 16 millimeters. Upper GI series, elongated pyloric canal, and it's called a shrink sign, indentation on the antral outline. We can do laparotomy, or we can do open surgery for the management of infantile hypertrophic pyloric stenosis. We do cut, then we do split. We don't enter into mucosa, into lumen. No non-operative option. We do either surgery, open surgery, or we do laparoscopy. We do a pyloromyotomy. Laparoscopic view we see here. Kası kestiğin zaman içeriki pasaj eski haline dönüşüyor zamanla. And this is infantile pyloric hypertrophism.